Good afternoon, everyone. I'm Richard Hara, and this is Social Impact Live, your weekly conversation with members of the Columbia School of Social Work community. I'm pleased to welcome to the program today Timothy Hunt, who's an Associate Director and Research Scientist at the Columbia School of Social Work Social Intervention Group. Dr. Hunt has been at SIG for the last 14 years, and as we were discussing in the lead up to the program, has extensive clinical experience on top of that, which I'm sure informs his work now as a co-investigator for the NIH-sponsored HEALing Communities Studies, which we featured on the program previously with various guests. As a reminder, it's a landmark study looking at how we can reduce opioid-related deaths in 4 states, I believe, over the next 3 years. And Tim, you're a co-investigator for the New York State portion of this project?
That's right.
Yeah. So we're going to be talking about the impact of COVID-19 on not just this project, but more generally on the people who are caught up in this opioid epidemic. So can you give us a little background either to the project or where we stand with opioid deaths presently?
Thank you, Richard, and for this opportunity to talk about these co-occurring epidemics and collisions, as we were talking about, between a pandemic and an epidemic. We launched the study last April, engaging our 16 New York State communities in a community-led, data-driven decision-making process to lower the opioid overdose deaths by 40% during the intervention period. As we know, we've had this critical issue to address for many years, with sometimes 130 people dying a day in the U.S. from opioid overdose. And here we are now in the middle of a pandemic where New York State is leading this pandemic with today over 10,000 deaths. So it's been quite an experience being in the community, leading the intervention so far in our initial wave 1 communities in 8 counties here in New York State. There have been some early progress in overdose deaths reducing over the last year. Very preliminary data from New York State Department of Health, our partner, looking at some somewhat lowering of overdose deaths, but these early trends we really need to look at more carefully and to see what now in the context of COVID-19, how things will change drastically.
Can you tell me a little bit about your specific role in this study and I think your connection with community engagement?
Sure. Along with our colleagues in the Social Intervention Group here at Columbia, as well as Dr. El Basel, the principal investigator, and our partners at University of Miami, SUNY, as well as NYU, certainly with Columbia and psychiatry. We have developed together with our partners in 3 other states, Ohio, Kentucky, and Massachusetts, an intervention called the Communities That Heal intervention. It is a 7-phase approach to engaging coalitions in communities to address health issues like the opioid crisis. So I've been working to develop the intervention together across the 4 states, as well as providing some lead in the community engagement work groups and focuses across these 4 states, and with our colleagues here in New York State, implementing directly with our county staff that we've hired as part of the HEALing Community Study. So I've been the privilege to be in the field, hearing directly from the way our partners at county health departments, public health, mental health are working with us as partners to address this issue. And now during COVID, how we're transitioning and adapting and supporting as they're addressing this epidemic and pandemic together.
And I think that's what a lot of people would love to hear more about, how you're adapting this, or the interventions in the face of this pandemic. Before I do so, just want to remind our viewers that you can submit your questions via the chat box on Facebook Live. We'll be able to answer them during the course of the program. If we don't get to them early, we'll get to them later during our final 10 minutes which we usually reserve for Q&A. So I just wanted to remind everybody about questions. So yeah, so on the ground, what have you heard, and who have you been talking to with regard to progress on addressing the opioid epidemic in the face of this COVID-19 pandemic?
Well, I really appreciate our brothers and sisters in the field providing direct care as they're really struggling not only to protect themselves while they're providing services to those with substance use disorders, which is of course the focus of our particular study, as well, especially with those with opioid use disorder. So we've been hearing directly, of course, how they are adapting very quickly and moving into new ways of service delivery now that regulations have been loosened by SAMHSA, as well by DEA, the Drug Enforcement Administration, on the way that medications for opioid use disorder can now be administered, the way that counseling can be provided telephonically. And so within a week or two, quickly these providers moved into action. We were there as much as possible to support them in that process. Part of our intervention is technical assistance and training, so we are there to offer that whenever possible. I have to say, right in the beginning, we moved from, our intervention launched in January for this particular wave of the Communities That Heal intervention. And so we had 2 or 3 face-to-face meetings, but then quickly moved into virtual meetings together. At first, I have to say, communities were saying, we're overwhelmed, we can't do this. You have to put this on hold. But I think through our dialogue with them, they said, wait, maybe you can be of support as we think about who are most vulnerable during this time. You know, those with substance use disorder, certainly we know are also at risk for other co-occurring and comorbidities, certainly chronic respiratory conditions, sometimes for those who are tobacco users or vaping, certainly methamphetamine users. So already may have had lung conditions that put them at risk for COVID itself. So on top of that, they're dealing with their recovery, whatever stage of recovery they may be in. And so the field has had to adapt quickly to make sure they have the services they need, moved into telephonic care. And we, as part of the study, were there to support them and also to see how we might even fast track certain strategies to prevent overdose at this time of COVID. We know, yes.
So let me just see if I'm following you correctly. So the majority of interventions are really geared towards supporting existing programs that are there to address issues related to substance use disorders. Is that, I mean, treatment
Certainly.
programs, things like that, and training healthcare providers, for example, to be able to administer naloxone and you know, in emergency overdose situations. Is that primarily where?
Yeah.
Yeah.
Certainly there are 3 primary practices that we're focusing on that have shown evidence to reduce opioid overdose death. Those are certainly overdose education along with naloxone or Narcan to reverse the effects of an opioid. Secondly is increasing the access to and retention in treatments that include medication for opioid use disorders. So we're talking methadone, we're talking buprenorphine, naltrexone, and then we're also talking about enhancing safer prescribing of opioids. So in the way those are dispensed. So these 3 primary practices are the focus of the intervention, along with communication campaign that supports awareness and anti-stigma that gets in the way of accessing those practices.
I have a question that from the audience that's directly related. Can you start methadone or buprenorphine telephonically without an initial face-to-face initiation? You talked about, you know, telephonic services now.
Absolutely. And this is what's been quite amazing. Advocates have often, for a long time, talked about the need to loosen some of the regulations on the way some treatments are conducted. This, in the middle of this crisis, has brought this somewhat opportunity in that, for example, buprenorphine can be begun with a telephonic initial session. And follow-up prescriptions have been expanded according to SAMHSA and DEA. So that has made maybe access to those who were ambivalent about starting treatment. Maybe they would do it more likely if they have telephonic services. When it comes to methadone, you still need an initial session to begin methadone. But what has never happened in decades, that SAMHSA is encouraging take-home of medication for methadone medications. Yeah. For 14 or 28 days, depending on how stable a patient is. So I've even heard stories directly where now that programs are delivering methadone to someone's home as part of the protocol for those who could not get out because of other conditions. So the field has had to be very creative in the way they're introducing and keeping the treatment going.
So all of this is a demonstration of how much all these social distancing and kind of quarantine guidelines, et cetera, are affecting both the provision of services and also the training that you're doing for providers out there. Agencies were feeling overwhelmed, but are they sort of settling into a new normal now and adjusting their practices as needed?
Well, I'm not sure about settling into a new norm, but absolutely, they have made a lot of progress. And certainly, there are some training requirements that have also been lessened during this time. The training and technical assistance we will provide and are providing certainly is now virtual. And our meetings of interventions are all done on Zoom. We've had meetings for 48 people at a time using breakout. Discussions has been quite productive, and communities have been amazed at how they've been able to engage and wanted to engage during this time when they themselves might feel isolated.
I want to just to return to just the overarching approach to this program. We have a question asking, can you discuss the theoretical frameworks guiding intervention development and community engagement, and how are data collection analysis, changed in this era of pandemic?
Wow, what a large question. And
yeah, sorry.
To spend a few hours on that one. This isn't an implementation trial, so we are looking at the factors that inhibit or facilitate adoption of the intervention itself, Communities That Heal, as well as the outcomes of the practices that we're supporting implementation around. So the PRISM REAIM framework we are using as far as guiding the study itself. Again, I said it is a community engaged process. It was built on and adapted from the Communities That Care model, which has been used for many years in communities focused on substance use for youth.
Okay. Another question from the audience. Can you talk about some harm reduction measures specific to COVID? I've heard recommendations to have people get more of their drug of choice to reduce chances of going into withdrawal or to avoid going into hospital for detox. Yeah, and I think we were also talking about drug supply and things like that. So yeah, before. So what are some specific to COVID harm reduction measures that are out there?
I think maybe the question is addressing two different things. There's a perception, for example, that there is harm or diversion possibilities for buprenorphine, especially as we work in jails in all of our 16 counties, and also we're working with the Division of Corrections as well for those coming from prisons. There's somewhat a myth around that. There are only very few cases where diversion is happening within jails, and there are protocols that have been shown to be effective to reduce the likelihood of that. When it comes to harm reduction principles and philosophy in general, we are incorporating that as Narcan itself is considered a harm reduction strategy, which has been led by harm reduction programs, especially in New York State, through the OOPS program with the Department of Health. Where it has started in syringe programs and other harm reduction programs to disseminate those. So of course, now it's much more widely disseminated, and we're supporting that in a fast track way with our our communities now. How to get Narcan to those families, friends, network, peers that may need Narcan to actually save a life while that person is considering their relationship to the substance use.
A follow-up question that I have here, and this is getting pretty technical for me, so you'll have to bear with me if I'm not getting the terms quite right. I have heard that people dissolve Suboxone films and snorting the buprenorphine. What measures do we have in place to discourage medication diversion then?
That's what I was just referring to.
Yeah.
Certainly in settings that congregate care, like in jails or prisons, there are protocols that have been shown to reduce the likelihood of that happening. And all of our partners are telling us about how effective that can be. There's a directly observed also medication processes that are being done via video now. So there are lots of creative ways that medication now is being disseminated and in practice, as well as there's a new strategy with surrogate care, for example. So doctors are allowed to bring in a surrogate who will help monitor and support the use of medications at home. And so that's another creative strategy that might be used.
Okay, thank you.
The long-acting buprenorphine also through injection is another strategy that reduces the likelihood of diversion as well.
Okay, thanks for that more detailed explanation. Another question that are Data 2000 waivers and increase in allowed patient numbers being expedited now? What sort of turnover time is expected? So I assume that this is a specific piece of legislation or guidelines that are in place that, yeah.
That's right. So again, we are supporting medication for opioid use disorder, and buprenorphine waivered doctors, nurse practitioners, physician's assistants can implement that particular medication. Okay. There has been a fairly stringent process of waiver where doctors were allowed or providers were allowed to have 30 patients during that first year, and then it was raised the following year. So they have not changed that waiver process right now. There may be some loosening that will continue there, though. But what we're seeing more often is that doctors who are waivered are still hesitant to actually prescribe. And we're here to support those doctors in addressing the fears or maybe even stigma toward those with substance use disorder that may get in the way of providing services. So a lot of doctors out there, a lot of providers aren't using all the waivers that they have. Telephonic may help those, especially in rural areas where they don't have providers, to be able to go across county lines to be able to access services. So that's something that could be very helpful.
So, and the reasons that doctors are hesitant to utilize these waivers, what are they?
I think we have to step back and know there is still a major stigma toward those with substance use disorder in general, not really recognizing that it is a chronic brain disorder, right? Lots of science around this. It's not just a lack of character, which many people in our communities, still think. That, again, this chronic condition needs to be treated with empathy and compassion. So there's a perception that someone walking into a private office, a primary care office, or a hospital setting will disrupt the setting, for example, if they have a substance use disorder. So these kind of stereotypes have to be addressed, as well as organizations need to be supported in setting up protocols that help address those patients. Now, telephonically, again, that's changed quite a lot. We actually support a lot, and we see the effect of peer navigation for care. So it's been a very effective strategy, linking people with who can understand and be empathic as they link them into care and support them in care. Now, during COVID, new strategies around protecting those who are doing outreach work have been instituted. One example we have, for example, in Columbia County, where there are outreach workers going out door to door dispensing Narcan in their protective gear as a way of making sure communities have Narcan during this time of isolation. Isolation is the number one risk for those in substance use disorder. So relapse is quite potential here. I have also seen 12-step programs going online have become very effective. So new ways of supporting those with substance use disorder is really taking place during the time of COVID.
Well, I've got an alum chiming in here, says, I work for the Pepperdine MFT program, and as a practicum coordinator, we're seeing many services moving to telehealth. The issue we're seeing is getting people to utilize telehealth. Any tips on how to make telehealth more welcoming to people? Yeah, I mean, if we're transitioning, I mean, how do we train and support the people who are now working telephonically?
I mean, I just like Richard, you and I are getting used to FaceTime and Zoom, right? I think the providers in the field have had to get used to being to providing telephonic services. So the more comfortable we are, the more comfortable our patients, our clients will be, of course.
Mhm.
The other risk, though, is those health disparities that did exist already, and we're seeing also those African American and Hispanic people are suffering much more COVID deaths right now than the general public, and we have to think of access to telephonic services. Maybe they don't have smartphones. Maybe people don't have the minutes on their phone to actually do that service. So I think we as funders as well as protocols have to be developed to make sure access is made possible for all those who need it.
Mhm.
And I actually have heard new strategies, new funding streams that are happening around how to enhance smartphone access as part of this process.
Okay, so on top of that, but I'm just curious, is there still outreach in or at other sites, person to person? You mentioned people going door to door and so on, and I recall reading somewhere that there was trainings that were going on in emergency departments and in jails and so on, and maybe you could speak to what's happening in New York State, but also with regard, if you've been in touch with other states as well, is this something that is really kind of applicable, really outside of New York State to the rest of the country?
Absolutely. So we have daily calls with our sister states, Ohio, Kentucky, and Massachusetts, and their implementation teams and investigators. So we're hearing the diverse strategies to engage the field at this time during COVID. Of course, New York, being the epicenter right now, has a bit of a different context than the other states. But certainly outreach has had to shift. There are programs, however, there are detox, rehabs, there are drop-in centers that still have reduced hours available. Staff, I did hear, though, there are cases, for instance, in New Jersey, where syringe programs, 4 out of the 7 closed temporarily. And so each organization's having to try to decide, how do I stay afloat? How do I keep my staff engaged and protect them at the same time? There is a peer navigation community in Cayuga County, for example, that's continuing to send out their peers with training of how to make sure they're safe. They respond to non-fatal overdose. They still go and provide Narcan and Narcan training, but they very much make sure they're managing their social distance at the same time. So there is a balance going on definitely in the field. I
Okay.
mean, we're all moving to virtual, right, for training and technical assistance. Our UNICEF project at SIG, for instance, which was supposed to be launched this month in 3 countries, was put on pause, and we're being asked now to move toward a virtual strategy when it comes to building capacity in 3 countries, with 3 other countries waiting for our support in social work.
Yeah, no, I think at some point we'll need to invite you back to the program to talk about the more international aspects of this work and the programming and what we're learning from it. But I also know that your work involves more policy-related issues, right? It's not just simply, or it's not focused necessarily only on the ground practices, but also what can be done in terms of public health policy and so on. And I have a question, or maybe this is a comment from one of our viewers. Corporate practices have not been fully supportive, even if individual practices are. Large practices need help and encouragement to create integrated pain management protocols that include MAT. So is this something that needs to be addressed by policy, state level, federal? What are your thoughts?
Well, I have to say, we do have the full support of our partners at the Office of Addiction Treatment and Services and Resources. as well as the Department of Health. And they are fully supportive of making sure these counties and communities have what they need to implement the medication-assisted treatment for opioid use disorder. I think partially it is the field itself, and we will provide technical assistance and training to help people understand where it fits in a recovery plan, where it fits in each implementation site, whether it's a primary care practice doctor or maybe a pain management clinic. Where do they need support and training to help them engage their patients in dialogue about how to be safe with the medication they're using? So policy level, we have a state CAB, state advisory board, where we have very senior level commissioners, as well as people with lived experience on that CAB. And they're providing us support around policy and planning and funding as well.
Okay. All right, now I'm going to take it back to the sort of ground level and a direct practice question that somebody's asking. I've found a lot of my clients who want to go to an inpatient rehab or a methadone clinic have found it difficult to find programs accepting new clients. Is that a problem now? What's being done about it?
I have to say that's probably varied across New York State, certainly, or in each region. On our coalition calls specifically, we found that providers are talking directly. How many beds do you have? Do you have openings for detox? And what we're hearing is there are still openings available, whereas maybe a program that was smaller or under-resourced had to close. So there's been lots of collaboration and coordination that has to have taken place at this time. Suffolk County out in Long Island is doing an amazing job of coordinating care, bringing their providers together to make sure that the continuum of care for substance use disorder is addressed. And so I think that we need to stay connected. I hope that they know, the people on the line know how to reach us as well for additional questions. I certainly am available. My colleagues at SIG are available. And certainly in our new center, by the way, that is chosen, is just launched. We're looking at all the factors that people have been asking about today to see how not only are we adapting right now, but once COVID has settled down, what changes in the system will have remained and how we might want to support those changes.
Yeah, it's interesting. There's a comment here that inpatient detox units in hospitals are being closed and repurposed for inpatient acute medical care because of COVID. So we're seeing different configurations, and we'll have an opportunity, hopefully, once the pandemic starts to settle down, to sort of look and see how can we deploy our resources in the best possible way.
Absolutely.
Yeah.
The people were vulnerable with the substance use disorder, and they're even more vulnerable now. Isolation is certainly a trigger and a relapse, and we're really concerned about co-occurring mental health issues that might lead people to even end their life. So there's a lot of strategies that need to continue, and we're here certainly as the Healing Communities Study to support the communities we're working with. And of course, the School of Social Work, we're here to train people to make sure they're available, not only in person in the future, but telephonically as well.
All right. Well, Tim Hunt, thank you very much for appearing on our program today to discuss the impact of COVID-19 on the opioid epidemic and efforts to reduce opioid-related deaths by 40% through the Healing Communities Studies. So yes, thank you once again.
Everybody stay safe. Stay safe, Richard. Thank you.
Okay, thank you. That concludes our program for today. We are planning to have Dr. Zach Parolin come and talk about the effect of COVID-19 on poverty rates in the United States this Thursday at our next special edition of Social Impact Live. So until then, thank you. Take care. Bye-bye.